So good morning, my dear students. Today we will be having a discussion on the short case presentation. Basically, how we had two occasions where we have discussed how to present long case in the spine and also for the fracture neck femur. These are long case. And when you talk about this sort of case, this is short case. The presentation in short case and long case are a bit different in examination. So in case of your long case, you have to start with the elaborate history. But in case of short case, this is different. So all short case, you do not have to give so much elaborate history. Here you have to come to the precise points. So if I am asking you a question like this, what is your case? Then how you are going to present?
My patient name Gopal Das is a 59-year-old male. It's a case of right-sided patella fracture following history of self-hold.
Are you happy with this? You want to add something there? At least the duration. At least the duration is important. How long he is having. So here you have to give specific points. Not necessarily. And then also, did you mention about the age? 59. So he is a male, right sided fracture patella, 59 years out of duration of 90s. So that will give you the basic points. You do not have to talk elaborately, but you precisely what you have gained. Okay, fine. Then the next question is why you have said is fracture patella? Why? On what basis you have come to the clear conclusion that this is a case of your fracture patella?
So firstly, on taking history, the patient gave a history of self-hold with direct injury over the knee, and on clinical examination, on inspection, I seen there is swelling over the right knee with abrasion over the knee. There is no external deformity, but on palpation, there is marked swelling over the knee with bony gap is seen over the patellar region, and there is bony crepitus and tenderness is also present.
Yes, and it is a key clinical point. But in this case, to say that it is a case of fracture patella, that means getting a gap between the two fragments. One and also the capital. So if you are trying to do the movement relatively between these two fragments, you will come in. So this is the clinical way. So there may be questions with various steps. Then why they may ask you what is a patella? Can you elaborate what is a patella?
Patella is firstly anatomy. Patella is the largest systemoid bone of the body. It is it forms an articular joint with the distal femur and the proximal tibia, and forming the knee joint. It has
Okay, now tell us what is the anatomical importance of the functions of patella. Tell us what are the functions of patella.
The functions of patella are firstly it protects the distal femur from external trauma. Secondly, it provides the integrity of external extension mechanism of the knee, and in deceleration of the knee while running very fast or walking very fast, and also it also provides nutrition to the distal femoral condyle.
So, anyway, what are the, if you say that it is the extension mechanism, so it is one of the important integral part of the extension mechanism of the knee joint, as you say. Now if I say what are the other part, what are the component of the extension mechanism of knee joint? What are the component or other integral part of the extension mechanism of knee joint?
The retina.
No, not only retina, there are other things also there. Extension mechanism of knee joint means what? Quadriceps tendon, patellar tendon, also tibial tuberosity. So anyway, there is a disintegrations in the continuations from the quadriceps tendon, patellar tendon, up to tibial tuberosity. Anyway, there is a break. So it will necessarily affect the extension mechanism of the knee joint. It is the integral part. What is the, this is one. Number two, you said anything more about the functions of the knee joint. Does it help in doing some function of the knee joint? Since it is a part of the extension mechanism, necessarily it will help in doing the extension. But what is the difference between the extension of a person with patella and extension of a person without patella? What is the difference? How the patella is going to help you? Does it got any difference or no? What is the difference then? How it helps?
It helps in extension. Without patella, extension will be there, but it will be limited.
Limited means what? No. Anybody who can say.
Quadriceps acting as a leverage mechanism.
Leverage. Actually, patella is a pulley. So if it is a pulley, the efficiency of the extension mechanism will increase. Unlike supposing there is a pulley, supposing there is a string over here, you are going to do extension. If it is going over a pulley, the efficiency of the pull is more, and while it is parallel. Yes? So efficiency of this pulley, your extension mechanism is somehow more with patella. But one can do extension of the knee joint even with flexor patella. One. Number two, even without patella also, the continuation is more important to have extension. But efficiency is necessarily increased as a pulley of the extension mechanism. One. Okay, fine. What is the meaning of the deceleration? So you say how it helps in deceleration?
When a person is walking very fast or
Very
running,
fast.
it helps in when a person is walking very fast or running very fast, and while stopping abruptly, the patella helps in deceleration of the movement.
It is true. The sudden deceleration if you say otherwise without patella, he will go 2 steps ahead to make him stop. Okay. Then anything more than this? Anything more than this? Anything more than this? Oh, you can please. Yes. I don't know when it. I'm not a book on a like a peaceful language to what it is. देखा और सामने अच्छा हाँ ये साहब को आ गया है बोलिए anything more than this anybody who can add any important point to it so this is your protection mechanism so a patella acts as a shield घड़वाल बनता है ना वो घड़वाल and ढाल घड़वाल is just like a ढाल or what is that called shield. So if there is no patella, if somebody is falling or something hitting directly over there, then necessarily it is going to do the damage of the articular surface of the femur. It will act directly without patella. So patella itself is sacrificing itself to save the condyle. Yes or no? If the condyle is damaged, it may cause extensive damage to the extensive functions of the knee. So in other words, it acts as a protective shield, sacrificing itself to save the femoral condyle. So the articular surface is not damaged. ठीक है सर. So these are the important functions of the patella, anatomically, functionally, all these things are important. You say this is the largest one. How many articular surfaces are there in patella?
Majorly there are 2, and they are subdivided into there are total 7 articular surfaces.
7 articular surfaces. Yes sir. Which side is bigger and which side is smaller?
Lateral side is bigger.
Bigger, and it is being divided into how many parts? Do we get some additional articular surface in the Asians? Why so? What is squatting? But that help in the generation another articular surface. Which side is lateral surface is much better, bigger. Achha, okay, fine. ठीक है सर. You said it is a case of flexor patella, and anatomically these are the important functions. Next thing then, now can you tell me what are the mechanism of flexor patella? How it gets flexor? What are the mechanism?
Generally there are 2 mechanisms, direct and indirect, and sometimes combination of both direct and indirect.
Sometimes combination of direct and indirect. Sir, what is the direct mechanism and what is the indirect mechanism?
The direct mechanism is caused by direct trauma to the patella, and indirect mechanism is caused by the pull of the quadriceps muscle, which causes a revulsion fracture of the patella.
How in the X-ray can measure that is the case of direct trauma or it is indirect trauma?
Indirect
flexure pattern will be? Flexure pattern will be?
If the fragments are far, it is
What is the flexure pattern in case of indirect trauma? Transverse. Transverse you see in avulsion flexures are always transverse. If you see in the medial malleolus also, there is avulsion flexures or avulsion flexures of the obliquum because of triceps pull. The avulsion flexures are essentially transverse. So that is why the X-ray one can make out it is a transverse flexure, more likely it is a your indirect trauma. Then what is the direct trauma? How do you know it is a direct trauma?
Sir, combination will be there, sir.
Combination, posterior
Yes.
combinations of flexure may be different.
Less distance between the two fragments.
There may be more combinations, and combinations are mostly because of direct trauma. So indirect trauma you will get a transverse flexure, and in direct trauma you will get combinations of the flexures, so sometimes different from that of your pure head. If so, sir, what are the different types of classifications, types of flexures? These are for the mechanism of how causing. Now what are different types of flexure patella? Yes, sir. Tell us what are different types of flexure patella? Tell us fully, when you are in third year, you are supposed to know. This is undergraduate question. Sachin,
Transverse fracture,
transverse flexure,
vertical fracture,
Vertical.
vertical flexure. Okay, fine.
sleeve or pole fracture, fracture of the poles of the
Polar flexure. Yes. Okay, then
stellate pattern of
stellate flexure. Then anything more? Anything more in flexure configuration? Anything more? Yes, sir.
osteochondral fracture.
Osteochondral flexure. Yes, sometimes very rarely osteochondral. Anything more? One is not completed. At least one is stellate, but next thing one is comminuted flexure. So sometimes you used to say the marginal flexure also. Some longitudinal split will be there, vertical split is uncommon. Even in polar, just like polar flexure in upper polar, lower pole, you have polar flexures. And you can have a marginal flexure also, margin, medial margin, lateral margin, or vertical. One and a comminuted flexure is one, and osteochondral flexure is a sometimes very difficult to diagnose. For osteochondral flexure, what special X-ray you need to take for the osteochondral flexure? Skyline view, very good. Skyline view to see the undersurface of the patella and also patellofemoral joint. So that will delineate the osteochondral fracture. Otherwise, all the fractures can be seen in normal X-ray by AP and lateral view. AP and lateral view osteochondral fractures you will see in the skyline. Now, next question: can a person walk or stand or do extension after flexion patella or no? Always or not always? Not always. Yes. In where always, where not always?
When the medial extensor retinaculum is intact, sir, when the medial and lateral retinaculum are intact, sir, the patient can extend the leg.
Very good. Very good. Very right. It is true that the persons can able to do extension in case of patella flexor. In case where there is an integrity of your medial and lateral retinaculum, that is very important. There is a flexor is there, but the integrity. Now, can you from the X-ray, can you have some idea about the integrity of the medial and lateral retinaculum? Can you have some idea? Getting आपका कुछ आइडिया हो सकता है फ्रॉम द एक्सरे दैट दिस मैन मे हैव retinacular involvement or no? Yes, sir. Yes, sir. What?
In case of intact retinaculum, sir, the fracture fragments will not be displayed that much, sir.
That's right. Very good. So a gap of the flexure will also reflect. Suppose you sometimes find the transverse flexure, one fragment is lying very high, another fragment is lying very low. So one fragment is lying very high, one fragment is lying low. It indicates the gap is small. Gap is small, it always reflects that the integrity of the retinaculum is also lost. So if the flexure fragment flexure is there, but displacement is not much. Flexure is there, not much. That indicates that probably there is integrity of the, and in those patients may very comfortably can walk you can have extension pull of the knee joint. But in a case where is rupture of your retinaculum, then he will not able to do efficient extension after that is the thing. That is retinaculum is a very important thing. It is surgically very important also. That is one. Okay, then what next? Now what are the, how will you proceed in this, then clinically how you have confirmed it. Then what next?
We give radiological investigation.
Radiological investigation. Okay, then what are the exercises you will suggest?
Firstly, AP, lateral, and if required, we'll give skyline.
Skyline view sometimes in traumatic situations very painful. It is true. But in a situation where there is no fracture, even your scene in your ABL, probably one can go. And skyline view sometimes very important to see the vertical fracture also. Vertical fracture sometimes in AP view obscure because your femoral condyle is also coming in between. If you take AP view, probably many times you may not able to know. And if you take a skyline view, you will find there's a split is there. And probably in a situation where there is vertical fracture is there, but there is no displacements. In this situation, skyline view will give better your idea about the fractures. The osteogonal fracture, sometimes vertical fractures are also seen in skyline view rather than the conventional views. Okay, what next?
After confirming the diagnosis, we plan for management.
Management, okay, fine.
There are two modalities. One is conservative and operative.
Where you are going to go for conservative?
Sir, if the fracture is undisplaced,
What do you understand by undisplaced? What do you understand by undisplaced? Chechen,
Intact extensor mechanism.
how do you know the extension of the intake?
Patient can do SLRT active.
No, that is not the, no. It depends upon the fracture. You are not, you don't know exactly the integrity. Sometimes they will be there, we look to MRI. That is not the idea. Idea is something different.
Rupture gap.
Gap, yes. What is the gap?
Less than 3 mm displacement. So, if the articular surface displacement is less than 2 mm, the fracture gap is less than 3 mm.
There are two things are there. One is the gap, another is the step. So ideally, better if it is less, it is good always. If you leave behind a step there, this is it will be very erosions on the articular surface of the female condyle and eventually end up with osteoarthritis of knee joint. So, but to some extent it is acceptable. It says up to 2 mm it is acceptable. If you have a step like this 2 mm or even a gap of 2 mm, up to that one can go for conservative treatment. But nowadays people are thinking now let us reduce it up to 1 mm. Okay, means that 2 mm one can think of going for a conservative treatment, but if it is more than this, you do not consider it. Basic idea is to reduce it and do not have a step over there. If you leave it, if you step over there, eventually it will unite, but it will finally end up with osteoarthritis and rest of the disease. It is not desired. So articular surface, essentially in other words, so to say, it is interarticular sort of fractures. Yes or no, articular surface is involved. So necessarily by principle in interarticular fractures, one should go for very good reductions of the steps and do a fixation so that he can have a early mobilization. If you want to go for conjunctive treatment, what is your line of treatment? In those cases where there is no steps or the minimal steps is there, how long and what is the modalities of the conjunctive treatment? Cylinder cast or slab, sometimes you can go for rigid spleen also nowadays. It's easily because you can open it and close it. How long? How long? How long, sir? 4 to 6 weeks. Usually 4 to 6 weeks is enough. And what are the other advices you are going to give to the person? What is the most important advice you are going to give to persons during this period of time?
Walking with extension.
Necessarily you are using a cylinder cast to prevent fracture. Why you are applying a cylinder cast? You do not want to get this fragment displaced. If you do flexion, So necessarily there is a possibility of pulling the fragments and get displaced. So this is not the idea. Idea is to maintain this position till it is united. But meanwhile, do give some exercise, advices. Exercise mostly the quadriceps. This is very important. The quadriceps drilling exercise to be continued because it is one of the muscles which rapidly goes for wasting. So that is very important. One can also work with some edge also. One can work, but necessarily you should not do flexion. So you can do his simple walks also. You can roam around with some support sometimes if necessary. Even without support also one can go. But necessarily do not do flexion, and also always do your quadriceps drilling exercise to maintain the quadriceps strength. Otherwise it will go for wasting of muscle. This is the most important advice you are going to give. Now what next? If you are going to for operations, how will you proceed? Oh, you are to be left. How do you proceed?
So indications for
Indication is already been decided. They say that if it is less than 2 mm, then we go for the treatment 4 to 6 weeks time, give proper exercise, can able to work with some aids. That is conservative. What about the property?
operatives are we go for open reduction internal fixation, sir.
Open induction internal fixation with what?
We can go for tension band wearing,
Tension band wearing. Okay.
and then for circlage,
And circulus wearing.
then CC screws we can apply, sir.
If it is so, there's okay, this is the patient here, this is the situation here. If it is so, now in this case, what is your line of treatment here?
Go for tension band wearing, sir.
Tension band wearing, okay, tension band wearing. What are the requirements for a tension band wearing? It is called modified tension band wearing. What is called modified? What is tension band wearing and what is modified tension band wearing? One is tension band wearing, okay, fine, that is accepted. Another is called modified tension band wearing. What is that?
In modified deforming forces.
No. Principle of tension band wearing is both.
Sir, in normal tension band wiring there is we form the 8, sir, 8, but in modified version we do not form the 8 version. We
What
have
you
to,
are finding?
we just uncircleize and then we have
I
to.
do not extend, otherwise they will load into that. That is the wrong thing you are talking. This is nowhere there. It is Agarwala's modifications of the tension band wearing not accepted. Do not utter the wrong thing, otherwise they will lock. I told you not, do not make the habit of talking wrong thing. If your wrong thing is there in your hard things, probably it will be there. Better not to utter. If you do not know, tell us do not know. But do not talk something wrong which you do not know. Yes, sir, you do know? You do not know. Okay, fine. Tension band wiring as a principle of tension band wiring is same. But here if you are applying the K-word, that is modified. Without also K-word one can do. Why do you need to give K-word? Do you give K-word? Yes, why? It is to prevent the displacement of the fragment. Otherwise it is not mandatory. A figure of it is compulsory. What are the requirement for, basic requirement for a tension band wiring?
Sir, the concave surface should be
Integrated. Correct. He is very right to have there. What are the different types of your tension band wiring? बोलिए. What are different types? ये तो principle हो गया. Types. Yes sir. Yes sir. What are different types? ये तो कोई से लुकी नहीं. I told you. What are different types? Ma'am. Ma'am. What are different types? Principle is different. Principle what he says right. You have to have an integrated concave surface. That is a must. Otherwise it is going to fail. What is more important? Types are two. One is called dynamic, one is called static. Dynamic is applicable particularly in case of oligonucleotide fracture, flexor patella. Static is mostly applicable for tension band wiring the medial malleolus, lateral malleolus, or even your data to canter also. Confusing anyway, but there is no question because this dynamic and statics are different. How do you differentiate these two? What is the basic principles? What do you understand by that?
In dynamic EVW, sir, we convert the deforming forces into compressing forces. Whereas in static force,
remaining static. Yes, by that is not the thing actually, it is movement. Movement will do it. So if you are giving a tension when running Oligan or a Patella also, if you do not give movement, the dynamic principle is not applied. Dynamic means once you do the movement, that is mechanism is so that it will go for the compression at the concave surface. That will accelerate. That is called dynamic compression technique. Yes, that is dynamism. Dynamic. But that is not applicable in case of flexor millioners because it's static. You cannot do the movement in the axis. You have to do the axis movement in the axis parallel to the flexor. Parallel to the flexor line. So that is why. So that is a tension flexor. Tension bend varying. Give movement, good fixation. It will accelerate. It will help with your compressions. That is same principle applicable for ligament flexor also. But this is not possible in case of your static or median relation lateral relation. Yes, sir. So, what are the size of the KOR you prefer? How do you do the reductions? Before that, what is the incisions? What are the incisions? Longitudinal. Okay, can you go for parallel? 10% incision? You cannot. You can. Sometimes it is also logical to think of it in a particularly I personally feel. So 10% incision is sometimes a bit helpful in a case where there is widely displaced. If the fragments are very widely displaced, you will understand that the retinaculum is very torn. Yes? So in a situations while you are doing a surgery in case of your patella flexor, it is always mandatory to repair the retinaculum very nicely. Only mechanical job of the flexor patella is not going to help you. This is always mandatory to have a very good repair of the retinaculum as well. Otherwise, you will have chronic pain and still other problems will be always there. So, if the fragments are very widely displaced, it indicates that this retinaculum is torn to the corner. So, in a vertical incision, it is a bit difficult to do sometimes repair to the up to the corner, the extreme points. Only in these situations, I personally feel that if you do 10% incisions, only it will help you better to repair the retinaculum corners, the extreme points. So that is another way of selecting but this is a personal choice also. Hardly matters whether going vertically or horizontally, it's all the same. Only same. Yes. So that means after doing reductions, how do you confirm that you have a very good reduction?
By checking the articular surface.
Yes. How do you check it?
By palpating the
Palpation. If the rent is there already retinaculum, sometimes even people used to go for it. Sometimes also ball tip sort of thing can be applied from the articular surface and have a feeling. How is the steps? So this under surface is not thin and C-arm also not going to help you. But you must have a very good reductions of the articular surface. Otherwise everything is going to fail. Otherwise you will have a problem. So that is why good reductions in articular surface is very important. Once you are doing open, so your reductions need to be perfect. They are perfect or perfect. Then you, after doing it, you go for the wearing and do the fixation. The tightening may be there parallelly, but 2 knot or single knot also depends upon the choice. 2 knot, single knot, you know?
yes.
2 knot and single knot. 2 knot you can do tightening both simultaneously, both the side. That can exhibit better compression strength, more compression that will be done. So fixation is important. Then doing the retinaculum job, okay, that is one. In a case when there is a comminuted fracture, what is the next choice? Any type of your fixation, you know? And circulation, sometimes augmentations to your techniques can be done sometimes, okay, fine, but it is not enough. In case of comminuted fracture. What next? Yes, sir?
Collector.
No. No.
Additional cameras.
Additional screws. Sometimes original screws can be applied. You are right, because you are in a case of your community, you are doing a third fragment here also. If you need, you can do additional thing here. Additional screw can be applied. Even your 4.5 pencillers or cortical screw can be applied. You can do some additional cables. Yes, sometimes sheet space wear, sometimes horizontal space wear. But your idea is that it's supposed to have a very good reduction. In commuted fracture, even in commuted fracture, the approach should be always there to reconstruct it rather than excision. Excision is a very extreme point where there is very grossly commuted fractures. You cannot do the reductions and it's compound particularly. Compound, grossly commuted fractures and loss of fragment, where reductions and the fixation is not at all possible. That is the only extreme point where you go for excision to the patella, otherwise no. Otherwise always effort should be there to reduce it and fix it. In a polar fracture also, what is the treatment of choice in a case of polar fracture? You say, polar fracture, what is the line of treatment there in polar fracture? What do you do?
Try to preserve the patella. If it doesn't,
Polar fractures, there are two choices. Somebody used to excise it and repair it with tendon, but ideally bone to bone repair is much better than that of the bone to tendon repair. And advantage of the polar fracture distal is extra-articular. So it does not have contributions to the articular surface. So that is another advantage. If you have a step also, it's not going to hamper much. So that is why it is better to reconstruct it rather than excise it. So the bone to bone union will be far better than the bone and tendon repair. One can do the excisions and do the repair, but ideally bone to bone fixes is much better. That will give more solid because the tissue characteristics are same. Okay, after doing reductions or doing the what are the other advices? What are the other advices? You do the exercise. Knee bending is usually not suggested immediately after fracture because many times if you do forcefully it may hamper the, but one can go a bit slowly. But lifting up the foot, lifting up the leg, what is exercise? This should be encouraged. One can walk, but that's all depends upon your fracture configuration and the fixation also. Fracture configuration and the fixation also. Determine. Now, what are the complications of fracture patella?
refracture.
Refracture, yes, sometimes refracture may be there. Correct. Okay, fine. But okay, something more.
Post-operative what?
Post-operative, no, actually late. It is okay. Post-traumatic arthritis is late fissures, not early fissures. Very late, yes, you can have. And particularly in those situations where there is a committed fracture, where reduction was not very perfect, and steps were there, probably it may accelerate the process of your osteoarthritis, but typically always in late fissures. What are the early complications? Infection may be. Infection may be there, sometimes loosening may be there, so many things are there. But most important thing is stiffness of the knee joint. So sometimes legs, the extension leg and terminal range of your is sometimes jeopardized. So this leads to efficiency of the knee function is somehow hampered in those situations, and it all basically depends upon the physiotherapy program you initiate after operation, very important. So to build up the muscles, make it strong so that he doesn't have any problem like this, otherwise he may develop certain problem. And most of the time, if you do not give it proper physiotherapy, stiffness is always a problem. Otherwise, other problems are there. Osteoarthritis is very late fissures, not the early fissures. But these are the infection, loosening of the implants, stiffness are the more common problem you encounter. What next? Anything more? Yes, sir. Anything more? बताइए. Anything more you want to add? Yes, sir.
Will advise the patient to continue physiotherapy.
Physiotherapy means it is tailor-made. See, physiotherapy, what is the immediate advice you are going to give post-operative period? Immediately.
Immediately we will ask the patient for isometric quadriceps exercise.
This is called quadriceps drill. This is quadricep drill, you would always try to give. The patient once the pain subsides after operations, once to initiate the process of your exercise immediately. Not necessarily walking or nothing, but the exercise should be done immediately. Then always encourage to build up the muscle, otherwise this muscle will go for wasting. Then what is the most commonly wasted muscle in quadriceps? Vastus medialis horizontalis the key. What is obliquus? What is that? What is that? What are the different components of the your vastus medialis? Obliquus, what is the characteristic of the obliquus muscle? What is the characteristic of the obliquus muscle? Because it is a muscle which rapidly goes for wasting, and you find that is also important. What is two things I am asking. One is how it is get attached. One, number two, what is the functions of the muscle as such? Anybody who can know?
So it is embryologically developed earlier, so hypothesis to generate earlier.
Okay, but what is the importance?
Sir, it is inserted as a muscle. It has no tendon insertion.
Yes, it does not have a tendinous person. Quadriceps is the tendon that does not contribute to the contribute. Rather, it acts as a muscle to the upper medial part of the patella, and that is attachment. And what is the function, important functions of patella, this muscle? Anybody who know?
Prevents the lateral suppression of the patella during flexion and
To tram exercise is right. This is called dynamic stabilizer. Stringing. These are patella tracking. Patella tracking a very important thing. Patella is tracking the two forces working like this. If this muscle is wasted, then other part may pull, it may go for lateral side. So subluxations and other problems are there. This is called dynamic stabilizer of the patella. This is important thing. So that is why this is very important thing. Attachment is important, function is important, and also that is why you always encourage him to do exercise to avoid wasting of the muscle. ঠিক আছে then. এতিয়া